Okay, this is Pediatric Elimination. So Pediatric Elimination, we're going to start with assessment. We're going to listen for bowel sounds in all 4 quadrants. We're going to observe the umbilicus for any abnormalities. Infants and young children will often present with a bulging around the umbilicus or almost like an outie of a belly button, but it's often a hernia that they'll monitor, and sometimes they'll do surgery, and sometimes it'll kind of go away on its own. But you need to be sure and report any tense or firm abdomen or unusual tenderness to the physician. All right, urination, infants and children. Emptying the bladder is a reflex. The infant bladder empties at 15 milliliters every 15 milliliters, which equals 20 voids a day, approximately 300 milliliters per day. Okay. 2 to 3-year-olds, they can learn to control urinary elimination. Older children, the bladder can hold more, and the urinary output will then differ. All right, the kidneys. Kidneys grow as the child grows, especially in the first 2 years of life. So the kidneys in a child are more susceptible to trauma. Why? One of the reasons is because the kidneys are located lower in relationship to the ribs, and there's also less fat cushion around the kidneys. Right? As the child grows, the kidneys grow, and they don't reach full size or function until when? So again, I hope you're pausing this video and looking this up in your Leafer book to find these answers. You'll learn it a lot better. But the answer is adolescence. All right, newborn and infant GU. Genitourinary. The abdomen is dome-shaped. Gotta sneeze. Peristaltic waves, should they be visible? We know what peristalsis is. We've talked about that already. So should peristaltic waves be visible? No, they should not be visible. All right, bowel sounds are audible within 2 hours after delivery. So by the time the infant is 2 hours old, you're going to be hearing bowel sounds. The abdomen is soft without masses. There should be a 3-vessel cord present. So the umbilical cord, you should be able to assess 3 vessels. What the mnemonic for that is AVA, so 2 arteries and 1 vein, AVA, artery, vein, artery. You monitor for signs and symptoms of cord infection, which would be yellow or green drainage, redness around the site. Those are foul odor to the umbilical cord. Those are good signs of potential infection. All right, when should the newborn void by? So within 24 hours after birth. If the newborn has not voided within 24 hours, we may do a little tiny catheter, which is difficult to do on these little babies, but it is possible. And but we're also going to be looking into their intake as well. But we give them 24 hours, but they should void within 24 hours after birth. Urine looks light in color and odorless. There may be a pink or light orange in the diaper. Often this is very concerning for parents, but it's okay. This is called brick dust, and it is related to excess uric acid in the urine. All right, males and females can have swollen genitalia, which is normal. They may have smegma, which is this cheesy substance on males and females. You don't want to wipe too vigorously. This will come off on its own. It just wears off, but you're not going to wipe it off, okay? And it's not anything bad or gross. It just is. All right. Immediately report ambiguous genitalia. So what is ambiguous genitalia? This is why I don't like doing this lecture online. I like to get some feedback. But take a minute to look up ambiguous genitalia. What it is when an infant is born and you cannot tell if the baby is male or female. The genitalia is ambiguous, neither male nor female. All right, here's a picture of smegma. It doesn't show up real great on this when it's blown up, but it's just this cheesy-like substance in here. All right, female infant genitourinary. The term newborn, the labia majora cover the labia minora. You need to report if there's an imperforate hymen, which is the covering over the vaginal opening. Blood-tinged mucus they may have some blood-tinged mucus secretions. Number one, is that normal or not? The answer is it can be normal. And what happens? Why do they have this? What they have is actually, this is called pseudomenstruation, and it's actually related to the maternal hormones. And this can be normal. It's not a bad thing. All right, male infants. The meatus should be at the tip of the penis. That would be normal. If it's on the dorsal side of the glans penis, so dorsal side is top. So if it's on the top, it's called an epispadias. If it's on the ventral side of the glans penis, and ventral would be the bottom, it's called a hypospadias. We also have phimosis, which is a tightly adherent foreskin. This is normal. You never ever force the tissue over the glans penis. You never ever force the foreskin over the glans penis. Spontaneous erections are very normal in newborns. Okay. Here's a picture of your hypospadias on the underside of the penis. And here's an epispadias on the upper side of the penis. So the hole should be right here at the tip. Should be right here at the tip. And you can see that it's not. All right. Male infants should have rugae on the scrotum. What is rugae? All right. Rugae are wrinkles in there. So rugae on the scrotum. Both testes should be descended or down. Undescended testicles, undescended testicles are called crypcortism. And it does require medical attention. Now, usually they may have one undescended testicle, and it will, even within the few days that they're in the hospital, descend. And we just kind of watch it. They could also have a hydrocele, which is fluid in the scrotal sac, and this will make the scrotal sac look extremely large, very taut, very tight, almost like a tight balloon that's going to pop. And you can hold a flashlight under there and see that it's just filled with fluid. All right, toddlers. Toilet training begins in the toddler stages. I have page 412, so I hope that's the right. I think that should be right. Page 412 for suggestions on toilet training in your Leafer book. So toilet training begins. You have anal and urethral sphincters must be developed to the stage where the child can control them. So these people who are potty training at 12, I'm 12 months old, less than a year old, I think they've trained themselves, not necessarily the child. The child has to be able to hold urine and stool until they can reach the toilet. The child must have a desire to please the caregiver by holding the urine and feces. Okay? They have to want to do it. You can lead a horse to water, but you can't make it drink. Okay? You can't make them want to do it. 18 to 24 months is usually the very earliest that kids can get potty trained. And they should be able to stay dry for at least 2 hours before you even begin potty training. Okay? In my experience, girls have been easier to potty train than boys. And they usually will potty train a little earlier than boys. All right, the hospitalized toddler. We need to put the child on a toilet. Putting the toilet training child back in diapers should be avoided at all costs. So yes, it's going to be a pain, but honestly, 99.9% of the time, the child's going to have a parent with them that can help them with the potty training. So don't force what's easier for you onto the child. I mean, you don't want to have a setback in this potty training development. Provide potty chairs, and the nurse must try to comply with at-home training schedules and rewards and whatever it is that they're doing at home. You've got to continue that. All right, the preschool or genitourinary accidents, you need to treat them very matter of fact and provide the child with clean, dry clothing. Remind the child to wash their hands after toileting. Girls need to wipe from the front to the back. This is very important to prevent urinary tract infections. Bedwetting is not uncommon in the preschool age, and it's not a concern until the child becomes age 5 to 7. Okay? Oops, sorry. School-aged genitourinary. We have enuresis, which is involuntary urination, beyond the age of when the child should have control. So usually ages 5 to 7. So enuresis is involuntary urination beyond the ages of approximately 5 to 7 years. Boys do have more difficulty. They will experience enuresis more than girls, and it can be a physiologic or psychologic causes. All right, physiologic causes for enuresis would be a small bladder capacity, UTI, that's a urinary tract infection, lack of awareness of the signal to void. They just don't recognize that feeling. They may express resentment towards a family member or want attention. There may be emotional stress, and it could be a symptom or a sign of sexual abuse. Now, psychological causes are emotional stress. If the child wants control, you can wake them up in the night to toilet, limit their fluid intake, do pediatric mental health visits. The nurse must be supportive and let the child and caregiver vent as needed without judgment. Okay, that's very important. We tend to think, we tend to want to, I don't want to say force, but even unknowingly we encourage what we think is appropriate or right onto parents, and we can't do that. All right, encoparesis is the chronic involuntary fecal soiling beyond the age of the expected control, which is usually 3 years of age. If there is no organic cause, such as worms or megacolon, it can indicate serious emotional problems. All right, counseling is definitely needed. All right, elimination and specimen collection. An enema treatment for some can be a treatment for some disorders, or can be done before procedures. The type and amount of fluid differs by the age because of the size of the colon and everything. The nurse holds the buttocks for a short time after the enema is given to help retain the fluid, since they cannot control it. All right, a bedpan, bathroom, or diaper must be available before you start the procedure. Ostomy is a colostomy. We talked about this already, bringing part of the colon through the abdomen to create an outlet for elimination. It can be permanent or temporary. So just because you have an ostomy does not mean that it's a permanent procedure. Can be open air, could be have a bag, could be that Koch pouch that we talked about, could have an appliance that we use to collect the stool. Okay. We've got the ileostomy, which is a small opening in the intestine that drains the digestive enzymes and needs a device to collect the drainage. Why do we need to collect the drainage from an ileostomy? Okay, so I told you an ileostomy drains digestive enzymes, so we need to collect this drainage because digestive enzymes can cause significant skin breakdown. They are touching the skin. All right, then we've got urostomy, which is the elimination of urine. All right, urine specimen collection, our favorite topic. All urine is measured. If an INO is needed, whether in a bedpan, diaper, urinal, or toilet, you can measure with diapers. I'm trying to see if I talk about that more, if I want to talk about it right now. So let me see. Okay, don't talk about it any further. So how are we going to measure INO with a diaper? So what they will do is they'll measure a dry diaper. They will weigh a dry diaper on a tiny little scale that measures, very minute numbers. They'll measure or weigh a dry diaper, and then they will put the soiled diaper on there and weigh the soiled diaper. And that's how they'll determine how much urine the baby's had. All right, if we need to collect urine for tests, we may need to use cotton balls in the diaper. Or we may need to put what they call a U-bag on. And they'll put a few cotton balls in the front of the bag as well. And we'll adhere it around the labia majora or adhere it around the penis so that we can get a urine specimen on the baby or the child. We need to offer lots of fluids if we are especially getting a urine specimen collection. So we need to do this 15 to 20 minutes before specimen collection. We're going to clean the perineum before collection, and we're going to document the time, the amount, and color, the test that's desired, what the, we don't really have to document. Well, it depends on if we're repeatedly placing a U-bag on to try to get a urinary specimen and things like that. We may need to document the condition of the skin. All right, a collection bag is clean. We need to have the skin dry and clean. We adhere this apply the adhesive plastic bag to the skin over the penis or vulva. And then we replace the diaper and remove the bag as soon as the child voids. I think this is on page 498, scale 22.5 and Leafer. And if I was in class, I would show you a little, what we call a little U bag to collect it in. If I can remember, I'll try to bring it Monday. Or Thursday, I mean. All right. Clean catch. An older child can collect a midstream clean catch urine. If you don't remember what that is, look it up. We just talked about it on Monday. Clean the genital area, void into the toilet, void into the specimen cup, and continue voiding into the toilet once enough urine has been obtained. We can do a catheterization if a sterile specimen is needed. For infants and newborns, we use a small sterile feeding tube. Or you can use an indwelling Foley catheter if you need it to stay in place. In a 24-hour urine, that's all the things we've already talked about. It's kept on ice in a special container, and the specimen is sent to the lab when the full 24 hours is up. For stool specimens, we would test for occult blood, ova and parasites, bacteria, glucose, and excess fat. And to do a stool specimen collection, the nurse uses a tongue blade to collect stool from the diaper or bedpan. It must not be contaminated with urine. Must be labeled and delivered promptly. And again, we're documenting the time, the stool amount, consistency, odor, the test that's to be performed, and the condition of the skin, because if there's been some skin breakdown and had some bleeding, and that's going to come up in the test results, and we kind of need to document that. That's where that's coming from. Okay, so that was a short little overview there for pediatric elimination. Let me see here. All right.